Hello and welcome to our new topic. Today we will discuss general anesthetics, drugs that produce a reversible state of unconsciousness allowing surgery to be performed without pain or awareness. General anesthesia is not simply sleep. It is a carefully controlled pharmacological state involving hypnosis, amnesia, analgesia, and muscle relaxation, achieved by modulating neuronal communication throughout the central nervous system. So, let's start. The learning objectives are shown. The objectives of this lecture are to classify general anesthetic drugs, understand their mechanisms of action, pharmacokinetic properties, adverse effects, and clinical uses. The emphasis is on understanding how and why these drugs work, rather than memorizing names. Consciousness is a complex brain state involving awareness, perception, memory, attention, and volition. It is not localized to a single brain region but emerges from coordinated activity across cortical and subcortical networks. Therefore, anesthetics do not switch off consciousness at one site, they disrupt network integration. General anesthesia is a reversible state of unconsciousness characterized by comfort, quiescence, and physiological stability. Reversibility is critical. Unlike coma or brain injury, anesthesia allows controlled return to normal brain function. This distinction is essential clinically and ethically. Before anesthesia, surgery was limited by pain, shock, and patient movement, as depicted in this image in medieval Europe. Mortality was high, and procedures were brief and crude. This slide highlights why anesthesia was one of the greatest advances in medical history. During almost the same period, great physicians in Islamic world were practicing early form of inhalational anesthesia utilizing rehydrated sponges soaked in opium and cannabis among other herbs. They also practiced pain control and described detailed surgical methods, many surgical instruments, and catgut sutures. Soporific or sleep-inducing sponge was soaked in opium, mandrake, scopolamine like alkaloids, hyoscyamus, henbane, cannabis, and belladonna. The sponge was dried, rehydrated before surgery, and held near patient's nose to produce sedation, analgesia, amnesia and muscle relaxation. Thus, it was a pre-modern inhalational anesthesia. Then, there was a void, until a few centuries later when the development of anesthesia was incremental. Nitrous oxide, ether, chloroform, barbiturates, muscle relaxants, and modern volatile agents each addressed specific limitations of earlier drugs. Understanding this evolution helps explain current practice. The first public demonstration of ether anesthesia transformed surgery permanently. It effectively demonstrated that consciousness and pain could be pharmacologically controlled in a predictable manner. Anesthetics could be general or local, depending upon its spectrum of action. The general anesthetics in turn could be inhaled or intravenous, depending upon their administration. Historically, general anesthesia could be divided into following four stages: analgesia, delirium, surgical anesthesia, and medullary depression. Modern anesthesia aims to bypass delirium and avoid medullary depression through controlled dosing and balanced anesthesia. No single drug provides all desirable effects. Therefore, anesthesia is often balanced, combining hypnotics, analgesics, muscle relaxants, and amnestic agents to achieve optimal effect with minimal toxicity. Inhaled anesthetics remain central to anesthesia because they allow rapid titration and control. Their effects depend largely on pharmacokinetics rather than metabolism. Nitrous oxide provides analgesia and amnesia but weak anesthesia. Modern agents such as sevoflurane and desflurane offer better control with less toxicity. Older agents like halothane are now rarely used due to adverse effects. This coefficient reflects solubility in blood. Low solubility means rapid induction and recovery because less drug is trapped in blood. This concept explains why desflurane and nitrous oxide act quickly. Minimal alveolar concentration represents the concentration required to prevent movement in 50% of patients. It is a measure of potency. Lower MAC means higher potency. MAC is influenced by age, temperature, and CNS depressants. Agents with low blood solubility, such as nitrous oxide, achieve alveolar equilibrium quickly, resulting in rapid induction and emergence. This is why modern anesthesia favors low solubility agents. Most inhaled anesthetics are eliminated unchanged via lungs. Minimal metabolism reduces toxicity. Methoxyflurane was abandoned because extensive metabolism caused nephrotoxicity. These references represent the core authoritative texts for CNS pharmacology. Students are encouraged to use them not for memorization, but for understanding principles. This lecture serves as a conceptual framework upon which all future CNS pharmacology topics will build. Thanks for watching. Don't forget to like, subscribe, and share. Happy learning!